I'm going to start with a word, hysteria, from the Greek hystera, uterus. The foundational medical belief dating back to Hippocrates was that the wandering womb was the source of irrational, disproportionate, inexplicable behaviour in women. That when a woman presented with symptoms that couldn't be immediately explained, pain, dizziness, palpitations, fainting, sensory overwhelm, fatigue, the problem was probably psychological, probably emotional, and probably not entirely real. This wasn't fringe thinking, this was Hippocrates. This was the beginning of Western medicine's relationships with women's bodies, and it established a template that has never been fully dismantled. The 19th century industrialized the dismissal. Hysteria became neurasthenia, which became nervous prostration. Women were institutionalized for symptoms we would now recognize immediately as autonomic dysfunction: fainting, heart rates, dizziness, nausea, chronic fatigue, and inability to regulate basic physical responses to posture, temperature, and stress. The treatment was the resting cure: complete removal from activity, stimulation, and autonomy, bed rest, stillness, quiet, which for a condition like POTS is almost perfectly designed to make everything worse. Lying still is exactly what a dysregulated autonomic nervous system doesn't need. Movement, hydration, graduated activities, those are what it needs. The resting cure was the medical establishment's best answer, and it was the opposite of helpful. And the women it was prescribed to, you know some of them. Florence Nightingale, a woman who revolutionized nursing, who transformed military hospital mortality rates, who produced more detailed statistical analysis of public health than almost anyone in Victorian Britain, spent decades bedridden after the Crimea. Diagnosed as neurasthenic, told to rest, her extraordinary productivity, the reports and campaigns, correspondence that changed policy, conducted entirely from a sickbed that medicine insisted she stayed in. The condition that kept her there almost certainly had a physiological basis, but nobody looked for one. Charlotte Perkins Gilman, prescribed the resting cure by eminent neurologist Silas Vere Mitchell, told to live as a domestic a life as possible, to touch a pen or a pencil no more than 2 hours a day. She wrote the yellow wallpaper as a direct testimony to what the treatment did to her mind. The story of a woman driven to break down by enforced stillness and the removal of her intellectual life. She sent a copy to Mitchell. He never acknowledged it. Alice James, sister of William and Henry, spent her entire adult life catalogued as hysterical, nervously prostrated, constitutionally fragile. Her diary, published posthumously, is a precise and searingly intelligent account of a mind trapped inside a body that medicine had given up on. She died never knowing what was actually wrong with her. These aren't obscure figures. These are women whose names we know, whose works we've read, whose suffering was documented in real time. And still nobody asked the right questions. Then Freud arrived and the dismissal became theoretically sophisticated. Physical symptoms in women were no longer just weakness. They were repressed trauma, unconscious conflict, the body expressing what the mind refused to say, which sounds like progress, but isn't, because it still locates the problem inside the woman's psychology rather than inside her physiology. It still says the issue is not what's happening to your body, the issue is what's happening to your mind. The framework might have changed, but the conclusion didn't. Women were formally excluded from clinical trials until 1993, which means that for the entirety of modern pharmacology development, every drug, every treatment protocol, every understanding of how conditions presented and the progress in the human body, that data was male. The baseline was male. The definition of normal was male. Women's bodies were assumed to behave the same way, scaled down. They don't. They didn't even use actual blood to test sanitary products until 2023. Autonomic dysfunction presents differently in women. Pain presents differently. Symptoms clustered look different. Hormonal fluctuations interact with cognitive tissue, and the nervous system regulates in ways that we are still not fully understanding. Because for most of our medical history, nobody was looking. The diagnostic frameworks built on male data have been applied to female bodies ever since, producing entirely predictably a systematic pattern of missed diagnosis, wrong diagnosis, and delayed diagnosis. Not malice, architecture. But let's bring it closer to home, because this isn't just history. Joint pain in teenage girls isn't investigated. It's growing pains. She'll grow out of it. Debilitating periods aren't investigated. It's just how it is. All women have to go through it. Toughen up. Dizziness, racing heart, nausea, sensory overwhelm. Not investigated. That's anxiety, stress, pressure of exams, of work, of trying to hold everything together. Nobody refers. Nobody looks deeper. The message, delivered so consistently it becomes invisible, is that your pain is not a signal worth following. It's just something you endure. And by the time you're an adult, you've already learned to endure it quietly, because the alternative is being told it's in your head, and that's worse. And here's what makes it so insidious. Chronic, unrelenting, uninvestigated pain is one of the strongest predictors of anxiety and depression in medical literature. That's not an opinion, it's cause and effect. If your body hurts constantly, if nobody believes you, if nothing gets better and nothing gets investigated, your mental health suffers. Of course it does. That's not weakness. That's what pain does to a person over time. But when the psychological symptoms appear, they become the diagnosis. The anxiety is noted, the depression is noted, treatment is offered for those things, and the physical cause, the dysregulated nervous system, the unstable connective tissue, the POTS that's been misfiring since adolescence, disappears entirely from the conversation. The pain caused the anxiety. The anxiety obscured the pain never got treated, and the anxiety got worse. And at no point did anyone ask what started it. It's a closed loop, and women have been caught inside it for centuries. We stopped calling it hysteria, and we started calling it anxiety disorder, or depression, emotionally unstable personality disorder, somatic symptom disorder. The language is more precise, more humane, less overtly insulting, but the pattern is the same. Women and girls are diagnosed with mental health conditions significantly higher rates than men. EDS, a condition that predominantly affects women, that produces exactly the kind of autonomic symptoms that present as anxiety, takes an average of over a decade to diagnose. A decade, during which time many of those women will receive mental health diagnoses, not as well, instead. The label has changed and the instinct didn't. But here's where the argument shifts, because this episode isn't about blame. Doctors working within the framework they were given or doing their best with incomplete tools. Mental health conditions are real and they deserve to be taken seriously. The mind and the body are not separate systems. They are deeply, irreversibly interconnected, and pretending otherwise helps nobody. The point is, what happens when you reinterpret your own history with better information? The girl who was told she was anxious, the teenager told it was growing pains, the young woman told to toughen up, stress less, try therapy, rest more. What if she wasn't mentally fragile? What if her nervous system was physiologically unstable and nobody had the tools to see it yet? That interpretation doesn't erase years of wrong diagnosis. It doesn't give back the decades spent in the wrong treatment. But what it removes is the shame. It changes the story from I was weak, I couldn't cope, I was making it up, to I was right. Something was wrong, and the system wasn't equipped to find it. And that matters. In the last 15 years, I have been offered the inpatient pain management program 3 times. It's a 2-week residential course. You stay in the hospital and they teach you how to manage your pain. I have declined every time because after 37 years, I know how to manage my pain. I don't need a 2-week residential course to learn something I've been doing since before most of those doctors even qualified. But here's what I want you to notice. It's 2026. And Western medicine is still prescribing the resting cure. They've updated the branding. The wheel hasn't turned. I didn't experience this personally. I had a diagnosis from infancy. My symptoms were never anything but physical, never reframed, never dismissed as emotional instability. But I have watched it happen to women around me my entire life. In schools and workplaces, doctor surgeries, the growing pains conversation, the period conversation, the anxiety conversation, the quiet, persistent, ambient message that a woman's pain is probably not what she thinks it is. And I'm raising daughters with the same nervous system I have. They will all grow up knowing what their bodies are doing and why. They will not be told to toughen up. They will not spend a decade being treated for anxiety while something physical goes uninvestigated. Not because the world has fixed itself, it hasn't, but because they have someone who knows the difference, someone who knows the history, someone has read the closed loop clearly enough to make sure it doesn't close around them. For centuries, when a woman's body behaved strangely, medicine looked at her mind. That wasn't ignorance, it was a choice about whose experience was worth investigating. We're still making that choice. We're just more polite about it now. Built anyway.